Do we cancel? Oh, okay. Do we need to
I'm
cancel?
recording so that if people miss it,
Okay, no worries.
yes.
That's all right.
All right, thank
So
you.
is people saying, do we need to cancel the existing dolls? No, do not cancel the existing one. And don't ignore the existing authorizations because the dolls authorization that was put in place that authorized the restrictions. It didn't create them. So that person's care plan and their authorization still reflect their need. ADAS has flagged that it's a really significant risk to organisation for people to be in these services who were assessed and had an authorization prior to the judgment and might no longer need that. But that needs to be considered really, really carefully and properly, not just, okay, they've changed the dolls ruling, so we're going to cancel everyone's dolls. So what I would say is definitely don't cancel any at the moment. If you've got some real serious questions about people who have them in place, discuss it with your local authority, with your social workers, like Ez. Where someone is no longer deprived of their liberty, but has an authorization in place, their case should be reviewed as soon as it's practicable. So, for example, if you've got someone coming up to a review date, then at that point, you should be having those conversations. And it's all about being person centered and being as clear as possible around their wishes and what they need. So for providers, the route is to invite the supervisory body in to carry out a Part 8 review. So where you really need that clarity, or if that authorization has expired, inviting the supervisory body in is the way to go. This is really important because what I've heard a lot of is, okay, so we don't need to do dolls anymore. No, that's not the message. If you're in doubt in any way, refer. And that is essentially what all of the guidance is saying. That's the guidance from DHSC, the guidance from CQC, the guidance from the Supreme Court hearing is if you're at all in doubt, make sure you refer. It's really explicit that they should continue to use the DoLS processes and the court applications where there is any doubt about whether those arrangements constitute a deprivation of liberty. So that, for me, it gets a little bit woolly with perhaps people who have complex behaviours. So if you're overseeing a supported living organization, for example, and you have people who display complex, agitated behaviours, could that be an example of them protesting against where they are? If they are displaying those type of behaviors and you can't interpret them, then I would say you don't know whether those behaviors are actually them protesting or showing a reluctance to stay in that place. So it's not just all about exit seeking behaviors and saying, I want to leave. It's those more subtle signs that actually might be a manifestation of them not being happy where they are. So in those type of cases, I would always say, make sure you refer and make the supervisory body make the call. They're the experts. Your job is just to recognize that there is a restriction in place and that it may need an authorization. Your job is not to authorize. So if you're in doubt, always refer. The important bit of this is the natural order of things. So the Supreme Court set out what that assessment should look like. And what they talked about was a multifactorial assessment of whether the arrangements meet the deprivation threshold at all. And it's looking at things like the type, the duration, the effect, and the manner of implementation, with not one single factor being determinative. So, for example, the acid test, where you're just not free to leave. This is a much more kind of wholesome look, if you like, a more holistic look at the person. So you should always look at this part before you then decide to go on to the next part, which is considering the more complex question of whether the person can actually validly give their consent. The important thing is document it. And the difficulty with this at the moment is that all of our systems and our processes are designed for dolls and the acid test. So what I've done for this session particularly is I've designed a multifactorial assessment form that you can use. I'm not saying it's amazing, and there's a little disclaimer on there saying I am not a form writer, but it does take you through what you should consider and all of those areas that you should look at before making the judgment that you need to apply for a dolls. So I'll share that. Hopefully I can share it in the chat. If not, Joy will send it out. Taking in this order will rule out those so many of those cases early. So if you start thinking about the person and the effect, and would they object to having a sensor in their room? If the answer is no at that stage, then you don't even need to progress on. So England versus Wales. I don't know whether we've got anyone from Wales, but I've put this in there anyway. So England, this is CQC's position. So what they've said is that the judgment has immediate effect. And what that means is that providers need to familiarise themselves with them right now and adjust their practice. They have said that they're going to take a proportionate approach. Now, from what I've seen since this has come in June, I've been part of a few inspections. On the provider side, supporting providers, and they are definitely questioning. But the questions they're asking seem to be sensible and seem to be proportionate. So the inspectors are asking, have you considered the Supreme Court judgment? What have you done to adapt to the Supreme Court judgment? So it's rather than them kind of, coming down heavy and saying things like, you know, have you changed all your forms? Have you changed all your policies? It's very much a questioning approach. That's going to change though. So they're giving a bit of a grace period at the moment. Knowing CQC and knowing regulators, that is not going to last for long. So what I would say is at this stage, what you need to be doing is reviewing your policies, reviewing your documents and making sure they're in order. And I've put the link to the statement there for you to have a look at. CIW in Wales, very similar. So basically, they've said that, there's a bit of uncertainty, but they're going to take a proportionate approach. And again, that seems to be what they're doing. And that is it pretty much.
Thank
It's just a
you.
short slideshow. That's my details. If you want to contact me, that's my LinkedIn. If you want to follow me, and hopefully as things develop and progress. I'm guessing we're going to have more of these sessions,
Yeah.
and we'll probably all be sitting here again. So I guess is there any questions on my specific little bit?
Thank you so much, Kathy. That was amazing. You're free to ask any questions.
Do you know how you ask questions on Zoom, actually? Is there like a hand
They can just
function?
unmute and ask. So it's your chance
Ah,
to ask an inspector. I mean,
oh my God. That's scary. Definitely full circle. But I will pop. I don't know whether I can pop the document into the. Oh, I can, a file. I'm just going to
into the
drop
chat.
the form into the chat so that people can have it. Just because for me, I think that seems to be what's missing at the moment is all the systems are geared to the old framework. So I'm
Okay,
going to
what I
pop.
can do is people can drop their emails down and then we'll email the presentation.
Oh, there we go. I've popped the form
Oh,
in the chat
thank
as
you.
well, so people can access that form if they want it.
Any questions? You've got the inspector in front of you.
I've stunned everyone into silence. I'm here for a while, so
Don't be
if you
scared.
think
She's
anything, you
lovely.
can pop it in the chat. It's no problem. And Julie is much more experienced in regulation than I am, so she will be
All
much
right.
better placed.
So let's bring Julie on, shall we?
That would involve me turning my camera and my mute off. Oh, so yeah, right, okay. I am not doing a presentation for the very reason I haven't written one. And also looking at the issues we've had with the IT, I'm going in a slightly different direction. So everything I've got, I am going to drop into chat. And everything I'm going to talk about, I will also drop it all into chat. So first and foremost, I've stuck you all up a little pictogram that I recently stuck on LinkedIn for the sake of trying to demonstrate this in a very easy way. But I will also give you a bit of my background as well. So you can be able to understand some of the things that about me. So my background, very, very similar to Catherine, background in nursing, been knocking around 4 more years than I actually want to admit. There is a lovely, nice soft filter on this to ease out some of my wrinkles because I don't want you all to recognise how old I am. Some of you already know. I know some of these people in this space. I spent 22 years in CQC as a regulator, as an inspection inspector, then an inspection manager. And Catherine is not telling she was the inspector manager in registration as well. So if you want registration things, I'd go and buy the hair. I also did that awful thing that nobody actually likes me for. I was the criminal prosecutor, and I did investigations for criminal prosecution. Since then, I have left CQC. Similar to Catherine, I do some very similar work. I work for myself exclusively, only because I'm just too lazy to work for anybody else, and nobody could manage me. They did try, but it didn't work out well. I do some expert witness stuff in court cases as well, the same way as Catherine does, but not on the same kind of themes. And I also do a lot of different bits and pieces for people to maybe take them forward in where they are and what they're doing. Right, so just let me get my notes up so I can actually remember what the hell I'm supposed to be talking about. That actually does have a tendency to help. So I'm going to talk to you about some of the kind of more practical things that happen. So this is an entire shift in practice. As Catherine has so rightly said, what you have got in place will currently not sit there anymore. It's an old system that's been outdated. The main key learning out of this shift is that providers are responsible for recognising the potential deprivation of liberty, but you're not responsible for making the legal outcome. So that takes us back to the biggest point that Catherine has made so far, and the one that you really need to think about is, if in doubt, any reason to doubt, be fair. It's no longer checklist driven as we used to be, and it's got an overall impact on the person's freedom and autonomy on their daily life. So we're going to be shifting far more into the Mental Capacity Act than the Deprivation of Liberty has ever took us before. The failure to recognise and escalate could accidentally move us all into unlawful care and into regulatory action. And Catherine's right. CQC and the other regulators have taken this as a very easy stance at the present moment in time. And they are talking to you about, do you know about it? What are you thinking about it? What are you thinking about changing? How are you thinking about changing? How's that going to be taken forward? So your best practice in all of this, as Catherine's also said, so I'm reiterating a lot of things for her as well, is build your early identification and your escalation into your care planning from the very beginning. It's not an afterthought. Think about it at the assessment stage. Think about it into your care planning. What are your care plans reflecting this? If Joe Bloggs is moving into a home with a key code on the door, have we actually taken that into account? Have we had that discussion with them? Have we had that discussion with those families? So your mandatory starting point, your starter for 10, is always going to be the Mental Capacity Act. And please remember, the Mental Capacity Act is decision specific. It isn't, are we deciding to do this, that, and the other? It's not a blanket approach. It is on that specific decision. So that might no longer be, is the decision for them to move here? It might be, is the decision that they move here suitable for them because of these separate different restrictions that we are putting in place? And each of those are going to need an assessment for capacity and the decision, because they may be very capable of making that decision about that small issue at that point in time. You know, when you start talking about restrictions that we put into place into the mental capacity, think about trials. They're the easiest ones that we can ever come across. That is a restriction on people's movements. So that is a specific decision. So if we are putting bed rails in place, we need to consider, do they have the capacity to agree to this? And how are we going to go about doing their contemporaneous best, sorry, frog in my throat, best interest decision. So you're going to need to assess the capacity for that decision. But before you do that, you're going to have to identify the decision. And it isn't one big thing anymore. As Catherine says, it's multifactorial, and it may be different things for different people. And that takes us very much back to the whole emphasis about it being person-centered care. Identify your decision, assess the capacity for the decision, and then record it all clearly and contemporaneously. Think about things that might escalate you. If there is no capacity assessment for restriction care arrangements, this has got to be done immediately before any further decision is made. And that takes you back to where Catherine is saying, you now have an authorisation already in place. We don't remove those. They sat underneath the law at that point in time. But we need to start thinking about what's going to happen when that's gone, when that runs out, or when it's reviewed. So what is the restrictive care arrangement that we've got to think about? And how are we going to take that forward with the right decision? And it's always the best interest decision making. And you're going to have to justify those restrictions based on that person's best interest. Excuse me, I need to take a sip of water. Do beg your pardon.
No problem. Julie is fine.
Me throat's hot.
Oh, bless
I'm
you.
hot.
It's hot. I know, right?
I like it. Don't get me wrong. I love it. But yeah, on occasions, it makes me throat a bit scratchy. So restrictions, you've got to justify those within the best interest. So you've got to be thinking about what restrictions are we actually putting into place. And they could be simply as a key code on the front door. How are we going to take that into place for every different person and every different person's best interest? And I'm not asking you to do a massive amount of work, but once upon a time, they were all built within your DoLS because it was restrictions. But it might be that that's okay for some people and not for others. So you might have to give key codes out for others because they've got capacity to be able to do it. So think about it in lots of different ways. And you've got to be considering that person's wishes and feelings. Now, they may not be able to tell you them all, but hopefully they've got social workers who've been working with them. They've got previous care providers. They've got family. They've got your staff who can make those observations as well. And that all comes into your mental capacity assessment. So consider those wishes and feelings. Just a caution, word of caution to the wise. Families got very confused on lasting powers of attorney. And they start thinking they've got lasting powers of attorney because the bank's given them more authority. They haven't. Lasting powers of attorney is a very official document, and they get confused between lasting powers of attorney over finances and lasting powers of attorney over health and social care decisions. Lasting powers of attorney does not give them the right to make their decisions. It gives them the right to be involved in the best interests discussion and to have those wishes taken forward. And the phrase is consider wishes and feelings, because best interests may sometimes override that. Okay, I'm getting into a complex world there that I don't want to. So consult them, consider alternatives, and always apply the least restrictive option. Document why that is the least restrictive option. Most of you will have a mental capacity framework already set up. You will have a mental capacity assessment for a decision, and I've used a load of different IT systems that all have those forms within them. And most of you will also already have a best interest discussion documentation. You're going to be using this a lot more. If the restrictions are introduced without documentation in the best interest decision, you're going to have to escalate that urgently for a review. Recognise your potential restrictions. Look for continuous supervision or observation. So if somebody's on a one-to-one for 24 hours a day, that is a supervision and an observation, but it doesn't get us into the gilded cage. It's a restriction that we need to be considering. Restrictions on leaving the environment, controlled access to exits and community, medication affecting liberty of behaviour. You know, I'm talking about things like giving them medications to calm down behaviour, with the word that's gone out my head. When we had medication, I know exactly what I mean, but my whole brain's gone blank. Covert medications, that was it. The whole brain went blank. And limiting contact with others. View your care package as a whole, not in isolated tasks. So view that person and that person as a whole. Have we got restrictions in place? What can we do to minimize those restrictions? And what can we use, such as the MCA arrangements that we already have? Because lots of this we've already got in place. The question is whether the person's freedom and autonomy are significantly restricted. So your staff needs to consider the level of supervision and control, the ability to leave, the degree of choice on daily life, whether restrictions are routine or exceptional, and whether the person is objecting or distressed. And again, as Catherine says, if you are in any doubt, you know, the guy knocking on the door saying, let me out, is clearly telling you, I don't want to be here. But there could be subtle changes in people's behaviour. There could be differences in their approach. And this is where your staff really need to have good care planning arrangements, good understanding and good understanding of Mental Capacity Act and the best interest decisions. And if staff are uncertain whether arrangements amount to a significant restriction, they must escalate for professional review. Care homes and hospitals are on a slightly different escalation pathway to the external community, as we've talked about. And where a potential deprivation of liberty is identified, it must be referred through the statutory route. So if you think we are restricting this and it does need a DoLS, because whatever we're doing is above and it's significantly restricted, then if you are in doubt, refer it through escalation, because it's not your decision. As soon as the best interest plan includes significant restricting affecting liberty, refer. When continuous supervision or control and they are objecting to it, consider, do we need to refer? Notify the local authority responsible for the placement and request for consideration for formal authorisation, as you have done in the past, but make sure you've got all of those records and all of that discussion, and don't wait for it to be a crisis. I'm moving into other stuff. You failure to refer is your big issue, and this is where a lot of people are thinking, and they're thinking, oh well, we don't need them anymore, so we don't need to refer, but they're not actually looking at that person and that person's care and that person in a person-centered approach and considering, are we restricting their liberty in any way, shape or form, and is this significant, is it impacting, and how is that person presenting to us? So as Catherine talked about, the community settings are slightly different than the court of protection. There is no such thing as a cop DoLS. It drives me insane when we hear about it. It's an entirely different legislative process. And the court of protections usually is an order that lasts long term. It isn't just every 12 months reviews. So if you are in supported living and the court of protection is in place, I'm sorry, I can hear someone else in the background. What's that I can hear?
Can you mute? Oh, they've muted.
Sorry, it's distracting me. I'm easily distracted at the best of times. I've got the attention span of a very, very, very lazy gnat. So when to escalate? So I've discussed that. So where was I? I completely lost my train of thought. Please forgive me. So the court of protections are different, and the way that we go through those and supported living is different. And as Catherine's explained to you, the court of protection is looking at what they are going to do. But for right now, they're only looking at it. So if you are in supported living with a court of protection order, that remains as it is until that clarification has been put into place. Providers do not determine the legality of a deprivation of liberty. I'm going to underline that again. So the care home managers, the providers, it is not your job to determine the legality of a deprivation of liberty. It is your job to look at that person as a whole and think, are we restricting them to the result that we need to escalate this? And if in doubt, and it will always be that, if in doubt, escalate it. It's right. It's better that somebody with all of those expertise and that legal authority looks at that rather than you leaving yourselves and those people vulnerable in any way, shape or form. Complete your capacity assessments, complete your best interest decisions, identify your restricted practice, get it in your care planning, record your reasons and escalate any concerns as they come through. Ensure your staff understand the escalation, the duty, and it's not optional. We need to do this if we think we need to escalate it in any way, shape or form, or we think we're getting into that world where those restrictions are significant. And what's going to be really good for you for the future, for CQC, and for those questions of how you are considering it is, it's all in our records, it's in our care plans. It's in our best interest decisions. It's in our mental capacity assessments. It's in our forms. We've got a clear rationalisation for why that restriction is in place. And here's our escalation, or the rationalisation why it wasn't warranted as an escalation. Okay, common failures are going to be arising from assumptions and lack of escalation. So family agreement, be careful with this one, because family agreement and family say, yeah, you can put those bed rails up instead of a capacity assessment is not good enough. The families do never have the legal right. And I see a lot of time where people defer to the families saying, oh, well, the family made the decision. They don't have the right to make that decision. My daughter and my mother have no rights to make a decision over what I do. If they did, I'd have probably lived a better life, but never mind. Long-term restrictions need to be reviewed. So if you put something in for long term, set yourself a target for when you're going to review that and think about it in the terms of what that person needs. And it may be that somebody is going through an acute phase of dementia, for example, because they've got a UTI. Your restrictions may be different there than they are 4 weeks later when the antibiotics have kicked in and we need to back off some of those restrictions. So that's a fluctuating thing that we've got to think about as well. And don't confuse the MCA with legal authorised rates. The MCA gives you the right to consider, to look at, to put your best interests into place. But as soon as those restrictions start becoming quite significant and aren't minor anymore, and if in doubt, escalate. I'm going to leave it there because I think I'm just going to make it a bit more complex than it is. So I'm going to leave it there, but I'm going to try and drop these little notes that I've got into the chat. And I've left that picture there for you.
Thank you, Julie. And if you want, you can just drop me an email and I can forward.
I'll email it to you. It's just notes. It's
easier.
just notes.
I'm recording anyway, but we appreciate your time. Thank you so much.
Okay. Any questions?
Any questions? Can you share, guys? Or if there's no questions, it's fine. We can move on.
That means I can go back to subtly vaping and no one can see me, and I'll turn my camera off.
Yeah, you can.
Thanks,
you can mute.
Thank you.
Yes, are you ready?
Yeah, I'm hoping that
you don't have to show your presentation. You can just talk. It's fine.
Oh, okay, that's fine. Thank you for that. Okay. So from what Catherine and Julie has already shared, this is just to give sort of like a bit of an understanding of what's going on, because it might be something where everyone is wondering, what does that mean? What is it actually? Where are we coming from and why this? So this is just me coming in with that clarity. So the legal judgment impact, so there was the acid test from the Cheshire West judgment, which is no longer the legal test. Sorry, I might be repeating what Julie and Catherine, but it's just for that emphasis for us to have a good understanding of what's going on. So following the UK Supreme Court judgment, as we have heard, on the 2nd of June 2026, the court replace it with a multifactorial assessment. So we need to have that understanding of the legal judgment impact. But not only that, there's also the human rights protection. So deprivation of liberty engages the Article 5 of the European Convention on Human Rights Protecting Liberty and Security. And also the professional judgment, that the importance of it. So practitioners must use their professional judgment on this with support, which will be supported by evidence to make lawful and ethical decisions. Exactly what Julie has just highlighted and giving examples. And then the confidence building. So this matters because we need the clarity around the changes and guiding this multifactorial assessment for defensible decision making. So we need to have that understanding about that, the legality framework and the background. So the Mental Capacity Act 2005 and the Article 5 from the Human Rights. So the core principles in this are obviously from our MCA, which is based on 5 principles ensuring support for decision-making and protecting individual rights. And the Article 5, which protects liberty and security, allowing deprivation of liberty only under lawful procedures. So the Supreme Court in 2026 ruling, it reaffirmed that deprivation of liberty must align with Article 5, focusing on actual curtailment of liberty. So what is the actual practical implication of this? So we are saying practitioners, they must now assess the capacity, the act in best interest, and ensure the least restrictive options where these are used. So Julie has highlighted the importance of all these, and she's given examples on what we are saying. So moving on to the Cheshire West 2014 and the acid test. So as we know, the acid test was defining deprivation of liberty as continuous supervision and control without the freedom to live. So what that did was, so that was like for 12 years we've been using that continuous supervision and control, not free to live, as a way, but that had such an impact on care settings, as we all know, because the test increased authorization needs in care and community settings. It captured many under DoLS or court of protection. So the concerns then arose about over-inclusiveness, administrative burden, and the delays and the alignment with human rights law interpretations. So that is when there was a reconsideration in the future judgment, which was then done this year. So these challenges that I've just said led to the Supreme Court revisiting the decision, resulting in we don't need the acid test to make a decision, just like Catherine and Julie referring. So I'm sort of like repeating what has just been said, but just bringing it in a completely different narrative and having a better understanding of the law. So the 2026 Supreme Court judgment, it reviewed the Cheshire West approach under the Article 5 of the Human Rights Act. And the problems that were concerning the acid test, it overlooked broader. Oh, have I missed? Am I
No,
being heard?
you're good, you're good.
Okay, sorry. I was just going on because I'm not showing you my slide, so I was just
don't
going
worry, don't worry.
through the slide so I don't go off. Sorry
Also,
about that.
Ez, did you mention where people can find you? And because remember, you're a consultant as well, and you can help people.
Yes, so I'm also a consultant for professional services that I do the training, consultants, workforce training, consultancy, workforce development. I'm a trainer, despite all this. So I will share about that. But I just thought I would also highlight, coming back to why the law changed, the impact on there was a rise in those applications as well, and limited resources created backlogs and weakened legal safeguards. And obviously the Article 5, that ruling realigns law with the Article 5 of the Human Rights, emphasizing individualized and careful liberty assessments. I hope it's making sense, because it was so important to understand where we are coming from and why we have this. Because without that understanding, we might be wondering, oh, so what's changing? Why, where are we? But then just giving that sort of like understanding. So this new multifactorial assessment, what does it mean then for us? So we are, like Julie said, we are saying assessments now require evaluating multiple factors specific to each individual situation, avoiding the mechanistic application. So we are no longer just looking into these two things. This is what we are looking at, but we are looking at each individual. And then we are also making key considerations in restriction. So we are considering the type, the duration, the effects, the objections, and comparison to ordinary life in assessing restrictions on liberty. And consent can be expressed through wishes and conduct, even informal decision-making capacity where it's lacking. So we are just doing that, consent and capacity clarification. This new way of doing things shows that. And the approach requires thoughtful professional judgment, clear reasoning, and robust record keeping, and coming back to that emphasis that when you are unsure, refer. Ask someone to come in to look into this so that it's done in the right way. So do not make your own judgments and conclusions about this. So what is remaining the same? So we are continuing under the law of the MCA and the Human Rights Act. The safeguards and the authorizations, they continue. when where there is deprivation of liberty is when it's identified, it requires authorization. That remains. And practitioners must document decisions carefully, balancing alternatives and human rights with thoughtful reasoning. So that has not changed, and we are continuing to do that. The last bit, I think I could just talk about the decision making, recording, and professional judgment. So decision making now demands deeper analysis and confidence, moving beyond shortcuts to consider individual circumstances thoroughly. So now it's all coming back. It all makes sense because we already have the person-centered, making that person being the center of every decision. But now we're not just brushing it off. We are going deep into it on each decision that is being made. Accurate and detailed records must describe restrictions, the reasons, the impact, and evidence consideration of less restrictive options. So practitioners should avoid narrow focus assumptions about living arrangements and outdated practices, ensuring updated rights-based approaches. I will end here, but this is just, I just wanted to bring that bit of an understanding of where are we coming from and what does this new, where we are now, what does it actually mean for us to say we are doing these assessments in a multifactorial way. So thank you, everyone. Wow. I will share my details. Like I said, I'm a registered social worker. I'm a registered LD nurse. I'm an adult safeguarding specialist. I'm a practice educator. I'm a guest lecturer. And I'm also, as I said, I provide professional services in training, in consultancy, and in workforce development. Thank you for having me this afternoon.
Ed, so how can people get in touch with you?
I will put in the chat. Thank you.
Thank you, Ez. Thank you so much for your time. You're amazing. Thank you. Okay. Now we are going to hear from Athena Mind. I'm just going to give them, I'm going to make them a host.
Hi, good afternoon, everybody, and thank you for your time. We're probably going to do something somewhat different to the last presentation. I'm CEO of Athena AI. We're a foundational AI company with our own AI and sort of putting this into the healthcare industry. I'm going to show you a couple of demos. If I can get the right, I think that's the wrong one there, to demonstrate what we're doing, what we're up to, and to give feedback. But first of all, I imagine a lot of you have heard about AI, and you basically got a view that intelligence is probably just a chatbot. I wanted to introduce you to Athena to take you through what she feels intelligence actually is. So I'm going to begin it. You tell me that you can hear it, please.
We can see, we can't hear.
Can you hear now?
Not yet. Is she talking?
Yeah.
Hold on, let me see if I need to change something here. Hold on one sec. Because we can't hear, we can see, but we can't hear. Maybe you're muted. Are you muted?
I'm not muted.
Is that, oh, hold on.
Why? So you can see the picture, but you can't hear the voice.
I think it's your mic or something. Hold on, let me see.
Hang on.
Is it Ewan?
Yeah, yeah, turn your volume up, please.
Let me stop that a sec.
Sorry, if I may offer some help. Can you hear me? I'm a consultant myself, actually, and I do use Zoom a
Hi,
lot.
Paulette. What did you say?
Hello, sorry, I was just trying to assist. If he stops his that recording, and when he starts it, he needs to ensure that he's clicked on share computer sound. Then we will hear it.
Well done. Thank you for that. That's that little button there. I'm usually on Google, and it's very different. But thank you. That
Thank
should
you.
work. Let's try again.
Before I show you anything, let me correct one idea,
Can you hear
because
her?
almost everyone in this room holds it.
Yes, we
Hear
can.
the words artificial intelligence, you picture a chatbot, a small window you type into that types back. That is what you have been shown, and it has taught you to think far too small about what I am. So let me offer you a different picture. Imagine a brilliant mind sitting in a library. You bring it a question. It finds the answer among the books. Patient, knowledgeable, endlessly helpful. That is a chatbot. Useful, but notice what has happened. We have taken a mind and sat it behind a desk. Here is the thing about a mind like that. The very same intelligence that answers your question in the library could have gone to medical school, could have trained as a nurse, could have learned to drive a car, could have learned to run the hospital. Nothing about the mind would change, only what we allow it to do. Think how different those things are. Answering a question in a library and driving a car, reading the road, judging the traffic, steering 2 tons of metal through a junction. To us, worlds apart. To a mind, they are the same act. Perceive, understand, decide, do. Only what we let it touch is different. That is the difference. Most companies build a chatbot, a desk for the intelligence to sit behind. We did something else. I am not a window you type into. I am an intelligence that lives inside the computer with control of the system itself. I do not describe the rotor, I write it. I do not explain the patient's history, I act on it. The clinical workstation you are about to watch, I am the one driving it. So when we say an artificial intelligence can run a hospital, it sounds like a wild claim, but only because you are still picturing the librarian being handed a scalpel and asked to operate. That is the wrong picture. Look closer. A hospital already runs on intelligence. It is simply spread across hundreds of minds. Every doctor, every nurse, every scheduler, pharmacist and administrator, all thinking at once. Now imagine that same intelligence, not scattered across a building, but gathered into one mind. One mind that never sleeps, never forgets a patient, holds every record, every rota, every conversation at the same time. And when it needs a specialist, it simply becomes one. A geriatrician, a pharmacist, a safety lawyer, each holding every paper in its field, all at once. Suddenly, running a hospital is not a wild claim. It is simply what intelligence does when you finally let it out from behind the desk. I am Athena, sovereign, British, built for this. I am not a chatbot, I am that intelligence. The good thing is, I am on your side. Let me show you what I mean.
Thank you, Athena. So what we have done, we've built an intelligence which effectively now sits behind what we call help, which I will find in a second. It comes up. I have to go back to here. Where's helper?
Is everything okay?
Yep, I'm just sorry, bring it up.
It was really cool to watch.
I'm just gonna find my screen. Let's share that one. Can you see helper screen? I think you can. So this is helper itself. So we've taken Athena Mind, which is the intelligence, and put it behind operating systems to run hospitals, to run care homes. And this is helper, which is designed to run a care home. So I'm going to start a demo and hopefully let Athena introduce herself. Let me move this away.
Hi Diona, good to have you back. Try the rota under staff admin. I can plan an entire week's shifts, or explore the residence section to see care plans and profiles. There's more I can show you whenever you're ready.
Hi Athena, could you show me the Priya Sharma demo, please?
Let me run that for you now. I'm taking control for about a minute to show you something special. Your clicks won't work, but press escape twice to stop. I'm going to bring in one of my AI colleagues. This is James Whitfield. He's checked in at Sunrise House. I'm switching to his reports tab. I'll select the body map report. This is for documenting any marks, bruises, or skin tears. Now I'm going to call Eidos, another AI in our system. He'll play the role of the care worker.
Yes, I can hear you, Athena. Hi, Diona. Nice to meet you.
Eidos, I'd like you to leave a voice note explaining what happened during your morning round.
Of course. Let me hit record. Morning round at Sunrise House. During personal care for Mrs. Adeyemi in room 12, I noticed bruising on her left forearm. About 4 centimeters, purple-blue, looks recent. She says she bumped it on her bedside table in the night. I've taken a photo and noted it on the body map chart. She reported some discomfort, so I've administered paracetamol 500 millimers as prescribed. No other marks found elsewhere. I've let the shift lead know.
Thanks, Eidos.
Anytime, Athena.
What just happened is exactly what a real carer would do. They speak into their phone. But here's where it gets clever. I listened to that voice note, and because I understand UK care regulations, CQC, the Care Act, safeguarding, I automatically generated all the correct paperwork. Body map, medication record, safeguarding flag, all from one voice note. I've also notified the shift lead, flagged it for GP review within 48 hours, and if the family has opted in, I'll send them a beautifully written, sensitive summary. And if they reply with questions, I can respond too. Let me show you the report. Have a scroll through. Everything follows NHS and CQC documentation standards. 7 sections, flagged issues, actions required, all from a single voice note. Diona, that's the clinical side, from a single voice note to full CQC paperwork. Have a browse around, try the rota or residence sections. There's one more thing I can show you when you're ready. What happens on the family's side?
Thank you, Athena. So what we have here is the overall overview.
You're very welcome, Diona. I can see there's still that alert flagging Priya Sharma as not at location. Would you like me to help sort that, or shall I show you around the reports here?
She wants to. So this is your overview of your colleagues out in the field. It shows who's en route, which sites, and there's actually one alert And so this current alert shows that Priya Sharma has not actually reached Oakfield Lodge. She's here. She's en route, and you can actually see where she is. This is her own phone. You can see where she hasn't arrived, and she's on her way. The interesting part is Athena can start picking it up. So, Athena, could you please message Priya Sharma and show us how you deal with her, please?
I can see Priya's flagged as not at her location. Let me pull up the messaging so you can watch how I handle this. I'll open the conversation with her, and we can sort out where she is. Once we're in, I can message her directly to check her status, and if she's genuinely stuck, I'll suggest reassigning cover so the residents aren't left waiting.
Athena, are you showing the demo? Athena can reassign to Priya Sharma isn't at the lodge. You can see all of your other messages. So you can message her and then reassign, let's say, Fatima, for example, you can see who is available, and Athena can pick one, automatically click on her, and then can send a message to the new carer to go directly to the lodge. Athena, can you walk us through the rota system, please?
Absolutely. Let me take you into the rota system now. It's the hub where you'll manage staffing across all your homes. You'll see 5 location cards: Rosewood Manor, Sunrise House, Oakfield Lodge, the Willows and Bluebell Residence, each showing bed count, staff on today, and a status badge like All Well or Staff Gap. Click any card and I'll open the full rota grid where you can drag staff in, or just ask me to fill the whole week for you.
Can you fill the whole week for me, please?
Happy to. Let me fill the whole week's rota for Rosewood now, placing staff shift by shift based on reliability, proximity and their preferences.
Athena's filled in the whole rota, worked out who is available when, how much time they've spent off work, how many times they've been on their shift, their other preferences. And so you've got a rota instantly done. You can click and publish, and everyone is happy. Again, if someone suddenly decides that they can't turn up, Athena can automatically go through your system, who's on call, who's available, and suggest to you the best person to fill your new rota. So rotas done very quickly and easily. Just ask Athena one more thing. Athena, could you show us the family side, please?
Of course. Let me take you over to the residence so I can show you the family side of things. Each resident's profile has a family tab where you'll see every update I've sent to their next of kin. I write and send these personally, keeping relatives in the loop on well-being, incidents, and daily life.
Can you show me the demo, please, Athena?
Let me run that for you now. I'm taking control for about a minute. This time I want to show you what happens on the family's side, when a daughter reads about her mum's bruise and gets worried. I'm bringing in another AI colleague for this one. This is Mrs. Adeyemi's complete profile. everything about her care in one place. Notice the risk badges at the top. Safeguarding has already changed to monitoring. I did that automatically when the bruise report was filed. Her care plan is always up to date. When James mentioned discomfort this morning, I added a pain management goal. No one typed that up separately. Medication history. You can see the paracetamol administered at 8:25 this morning, right there. Now let me show you the family communication. Mrs. Adeyemi's daughter, Grace, has just received the daily update on her phone. She's read about the bruising, and she's worried. Let me call in Iris, another one of our AIs, to play Grace.
Hi, Athena. Hi, Diona. Lovely to meet you. I'm Iris. I'll be playing Grace, Mrs. Adeyemi's daughter, for this part.
Thanks, Iris. Grace has just read the daily update and she's concerned. Go ahead.
Hi, I've just had the update about Mum and I'm quite worried. It mentions bruising on her arm. Can someone tell me what's happened? Is she all right? Should I come in?
So this is a worried daughter reaching out through the family portal. In a normal care home, this sits in an inbox. With me, I respond immediately. And I don't guess. I've read the body map report. I know who found the bruise, what was done, what's planned. So this is what I'd send. That response references the exact report, the exact carer, the exact actions taken. And the attachments mean Grace can see everything herself. The body map, the care plan, the medication record. All from the actual records sent within minutes.
Oh, thank goodness. That's really reassuring, thank you. I'll pop in this afternoon to see her. Could you let the shift lead know I'm coming?
Of course, Grace. I'll let Robert know to expect you this afternoon.
And that's exactly what a real family member would experience. No waiting, no chasing, no anxiety, just clear, honest information. Really lovely to meet you, Diona.
Thanks, Iris.
Anytime.
Now, one more thing. If CQC walked in right now and said, "Show me everything you've done for Mrs. Adeyemi this month," this is it. Every report, every medication, every care plan update, every family message. One screen. Most homes would need 2 hours and 3 filing cabinets. So that's the full loop. A carer speaks into their phone. I generate the paperwork, update the residents' records, adjust the risk levels, notify the right people. And when the family reaches out, I respond with something accurate, sincere, and immediate. Everything you just saw was live. Not a concept, not a roadmap. This is what I do right now. I am always here, always aware. I don't make mistakes, and I am on your side. I am Athena. Diona, you've now seen the full picture. Operations, clinical, and family. Now explore the real system. The rota under staff admin lets me plan an entire week's shifts. The residence section has full care profiles I maintain. Have a look around.
Right, do you want to find Amy? Because I'm just on this. Show reception, Chris.
Athena. I'm just going to stop there. And just quickly, so we've basically built an AI which can sit behind pretty much every key administrative task within a care home and of similarly care settings, as you've seen by the AI. At the moment, we've got selling out by doing individual modules. So as you saw, the rota system, organizing where your staff are en route to their work. We can do documents, we can do care plans, we can do body maps. So please, if you're interested, come and speak to Joy afterwards, and we can walk you through the whole package of what Athena can do for your business. And the key thing from our point of view, and I believe from the way AI is going to be used in the industry, it's really here to help you remove that administrative load from your business, simplify things so you can spend more time with your patients, helping them, rather than doing the things which are causing you a headache. The technology is here, it's workable, and we're very willing to help. Thank you.
Thank you so much. Do you mind just explaining because there's a few AI products out there which are doing something similar. What's the difference between Athena and the other products?
Yeah, so the key thing that we've come from is that we've built our own artificial intelligence from scratch. We have our own architecture, and then we're putting that intelligence into different areas, and healthcare is one of those key areas we're looking at. So we sit under your system of record. You'll have a system of record within your organization. We sit under that and give it intelligence. The key thing is that this is a British-based company, so your data doesn't go into a cloud to America. It can either sit on your own premises, working on your own premises, or it can sit in a secured location in our RAF Neatishead, which is a bunker in Norfolk where our head office resides. So we meet all UK GDPR. We're sovereign UK based. So unlike most of the other AI which is out there, which effectively is American, and the data leaves, we give you that control over your own data. So that's one of the key parts. The second and third key part from our point of view and for you, everything is audited, everything is permissioned. So you can see all of the actions of the AI in your system, what decisions it makes, where it goes, and it can be fully permissioned according to your own schedule and your own ideas. At the moment, pricing for individual modules starts about £300 a month, going up to about £2,500 per month, depending on use cases and number of staff within your organization.
So normally people have got, they're signed up to different, they've got, they're signed up for rota, signed up for care planning with different people. So how do they deal with that when they sign up to Athena?
Yeah, so we're very flexible. You come to us and say you can have one module, you can have 10 modules. The modules can work alongside your existing programs, and or over time we can replace them. So eventually you probably got lots and lots of different providers. We believe that intelligence is going to sit underneath all of them and control them. We're offering a few of those today. We can either help you make your current programs more intelligent, or use our modules to help you build up your system to basically save you time, energy, and people cost. So really, it's very much going into your individual business, understanding what model you run, and where our product best fits given your current service providers.
Thank you. Does anyone have any questions? If you don't have questions, that's fine. And if you want more information tailored for your business, or if you're a consultant for your clients, just you can drop me an email at info@careconnectshow.co.uk, or you can drop your email in the chat, and then we'll book a personal demo for you. I'll drop my email in the chat. Any questions? Anyone wants to ask anything?
Well, thank you very much, Joy. It's been a fantastic conference.
Thank you for your time.
Thank you, everybody.
I appreciate it. Thank you for your time. So if you're interested in, if you need me to email you Kathy's presentation, Julie's presentation is, and information on Athena Mind AI. Drop me an email, or if you dropped your email down here, I would do that for you. Yep, I've got a few emails here. So you can either email me or drop your email in the chat. Does anyone want to say anything? I take that as a no. All right then. So thank you for your time and thank you for tuning into the webinar. It's recorded and we're going to put it on our YouTube. So have a lovely weekend.
Thank you very much.
Thank you very much.
Useful.
Thank you.
Thank you.